diploma in department. She will be talking about ectogenous fungal endophthalmitis. You know, after the surgery or cataract or vitrectomy, often the patient have endophthalmitis. The cause of endophthalmitis is very rare, but still happen. And for the fungal endophthalmitis is also extremely rare, associated with endophthalmitis after cataract surgery. Nowadays is 0.2% have endophthalmitis, but fungus endophthalmitis just around 0.002 case in endophthalmitis after the cataract surgery or vitrectomy. But nowadays we still have many cases very difficult treatment. And Dr. Zoom today she will be talking about the core and treatment in this case. Please for your presentation.
Thank you. Hello everybody, my name is Young. I'm a staff of trauma department. And today I'm so pleased to present a topic about exogenous fungal endophthalmitis. In this presentation, I will talk about two main parts. The first one is overview, and the second one is our research in Vietnam National Eye Hospital. As you know, fungal endophthalmitis is a very rare disease, and its causes include post-traumatic, post-trauma, post-operation, and keratitis. But in this presentation, I will focus on post-traumatic and post-operative endophthalmitis. As you know, fungal endophthalmitis has a delayed onset. In some previous research, it is 7 days for post-traumatic fungal endophthalmitis and about 20 days for post-operative fungal endophthalmitis. And we often misdiagnose because of the fastidiousous nature of fungi. And because it is very rare, so there is no level 1 evidence to guide management. To diagnose a patient with fungal endophthalmitis, we base on some characteristics of it. The first one is delayed onset, as I told before, and the size of fungal endophthalmitis is very variable. It can be from classic endophthalmitis triad, such as pain, red eye, blurred vision, to very insidious progress. And there are some special symptoms we should mention. The first one is keratitis or sclerosis association, with a very special characteristic is multifocal, and it also has clump inflammation in AC and BC, such as snow balls, snow banks, string of pearls, and puff ball. But unfortunately, puff ball is often a symptom of endogenous endophthalmitis instead of exogenous one. It is a picture of a patient who suffered from Fusarium endophthalmitis, and you can see there are many corneal invasion with feathery invasion on cornea and feathery hypopyon. There are many techniques, laboratory techniques to diagnose fungal endophthalmitis, and the first one, it also the only one we have in our hospital, is microbiological culture. However, as I see, it's rarely done in our hospital because it is time consuming, up to 2 weeks, and it has a relatively low diagnostic rate, about 13 to 70%, depends on the researches. And we have to use aqueous or vitreous stuff. And according to some previous researches, the sensitivity of blood culture bottle is higher than raw solution and solid media. The second technique I want to mention is detection of fungal cell work, such as galactoman or beta-glucan. But this technique, we only detect the fungal in blood for invasive fungal infection only. One common technique I want to mention is PCR, but now PCR is limited to detect only Candida species only. And the last one, and it is very potential technique, is next generation sequencing. It can detect all the different organisms present in a sample, but it's not variable now. Here are some common organisms in a research long et al. About post-traumatic fungal endophthalmitis. You can see there are over 50% of patients they have Aspergillus and Fusarium as the causes, and they are the filamentous fungi. One research of Nagang et al. About post-operative fungal endophthalmitis, you can see Candida accounted for about 20%, and 80% is Aspergillus species. I want to mention about some antifungals we use in clinic. There are two important class we should mention because they are variable in Vietnam. The first one is polyene, include amphotericin B and natamycin. Amphotericin B can treat Candida aspergillus and Fusarium. Indeed, it can treat most of pathogen of fungal endophthalmitis, but we should be cautious because of risk of retinal toxicity and punctate corneal erosion with topical use. The second common drug we often use is natamycin. However, actually natamycin is suitable to treat keratitis only because of poor penetration. The second important class I want to mention is ozone class, and fluconazole is a drug we often use in the hospital. And the second one is itraconazole, which is carbac. However, carbac has a disadvantage is unpredictable ocular drug levels. And there are two more class of antifungals I want to mention, but because they are not variable in Vietnam, so I will skip. As I told before, there is no one evidence of treatment fungal endophthalmitis, but there are some suggestions how to use medicines when we diagnose a case with fungal endophthalmitis, as you see on the screen. And there are some surgery often used to treat fungal endophthalmitis, including AC wash, vitrectomy with silicone oil, and evisceration. We implemented one research in Vietnam National Eye Hospital about exogenous fungal endophthalmitis to describe the clinical characteristics, paraclinical findings, and treatment outcomes of exogenous fungal endophthalmitis at Vietnam National Eye Hospital from October 2019 to October 2024. It is a cross-sectional and retrospective study. There are 18 patients diagnosed with exogenous fungal endophthalmitis confirmed by microbiological testing from October 2019 to October 2024 enrolled in this research. And the result, the male to female ratio is about 3.5 per 1, and the mean age is about 15 years old. The latent time is about 24 days for post-traumatic fungal endophthalmitis and 50 days for post-operative fungal endophthalmitis, and the treatment duration is about 26 days. This chart shows that the distribution of patients in different seasons, and you can see most cases happen in the spring and autumn, from January and March to March and July to September. The second chart shows that 70% of patients has post-traumatic fungal endophthalmitis, and over 30% is 50% happen after an operation. The visual acuity initial or finals are quite low. At first stage, one patient having visual acuity is 20 per 400, and only one patient with negative light perception. But at the end, there is no patients with visual acuity equal or better than 20 per 400, and there are 3 patients have negative light perception. There is no significantly difference of visual acuity between post-traumatic and post-operative endophthalmitis. Most of post-traumatic patients have a corneal abscess or ulcer association, and 100% of patients have a hypopyon or AC inflammation. There is a statistically significant difference in proportion of patients having corneal injuries between post-traumatic and post-operative group with P under 0.01. This chart shows that most patients have serious or extremely serious vitreoretinal images on ultrasound images, and there is no significant difference between two groups after trauma and after operation. 16 per 18 patients were used amphotericin B in multiple methods, topical or intravitreal. 14 per 18 patients use Carbax and systemic medicine, and only 6 patients having chance to use natamycin because sometimes it's not variable in Vietnam, and 9 patients use fluconazole subconjunctively. Over 60% of patients use 3 medicines to treat. 30 per 18 patients have vitrectomy, and 3 cases ended with evisceration. In our research, there is a very special case in which patient had vitrectomy at first, but after that, because the infection was not limited, leading to evisceration, and there is no significant difference in types of surgery between two groups, post-trauma and post-operation. It is the eye condition of this patient I have mentioned before, before the day of evisceration. We found that We found that the percentages of patients suffer from evisceration is much higher in groups of patients not using amphotericin B and having extremely serious damage on ultrasound image. So our conclusions include fungal exogenous fungal endophthalmitis is very rare disease, and it is difficult to diagnose because of the nature of fungi and lack of diagnostic methods. The disease often happen in the spring and autumn, and it is very regular. It's very often that corneal damage associated with fungal endophthalmitis, especially in post-traumatic fungal endophthalmitis. And 100% of patients have inflammation in AC, and it's very poor prognosis disease. About over 50% of patients will have an evisceration and the final visual acuity rarely better than 20 per 400. And there are some prognostic factors such as usage of amphotericin B and visual retinal images on ultrasound images. My presentation is finished. Thank you so much for listening.
Thank you very much for your presentation as a fungal endophthalmitis. There's any question or comment for Dr. Su? Yes, Dr. Good.
Yeah, thank you, Dr. Zu, for your presentation. Yes, I remember at that time I was working in trauma department. I met some patient with endophthalmitis by fungal, and so. And I remember it generally serious. Some who have endophthalmitis by fungus. I didn't cure for anyone. Almost I have to do with ABC acceleration. In your group, you do many like intravenous, intravitreous injection. You do the vitamin also. But at the end, I think that the outcome, visual acuity outcome is not so good. Why our limitation is that. And with your thesis, is it your master's thesis? You work together with Dr. Ben, you study in Tomato, with the department of your study. Okay. With 18 patients, the number of one usage, so yeah. You didn't mention about history of patient in the Asian, automatics Asian. For example, vegetable Asian, dirty land of soil, dirty something like that. You should explore, do the investigation about that. First thing. The second thing, how about the history of using medication also. If someone they have used cortisone, corticosteroid before enter the hospital, is quite should have attention about that. And second thing, the number of a group is not higher than 5 patients, so quite hard to do the comparison. I mean that's statistics method to do the make the comparison between this group to the other group. I mean that. Thank you.
Okay, thank you very much. So you have any question or comment? For myself, I read also the number of endophthalmitis, but often at least the patient echo changes in ophthalmologist. Whenever I meet the fungal in ophthalmologist, but I have one case is a long time ago, maybe more than 10 years ago. This patient, she have indoor genius ophthalmologist that been no have any surgery before, and I have already treatment for patient in vitrectomy and also put silicone oil, also injection in the vitreal cavity, and after the patient, I follow up the patient and still after the surgery put silicone oil inside, but the fungus still happen. But by the time it will be disappear, so that means the silicone oil can inhibit the fungal develop in the vitreous, and actually she don't come back to the clinic since a long time. But I know for, and also very afraid for the patient and also for the doctor, that the patient have a fungal in the ophthalmitis is a very severe disease and very difficult to treatment for the patient. So any other question at the moment? No comment.
Well, I want to answer a little bit about the question of Dr. Kuang. The first one is about the trauma of patients. Most of them have agriculture trauma, and I'm sorry because I not present in this presentation. The second question is about the number of patients. Actually, it's a very rare disease, and at first I decided to I want just collect the patient in 3 years from 2021 to 2020, 2021 to 2024. However, because of the COVID-19 pandemic, and it's very rare, so I have to expand the time from 2019. Yeah, and I think actually the number of patients is not exact, because it's very hard to diagnose, especially when we don't have many techniques, laboratory technique to diagnose. Yeah, so I think it is one reason why the number of patients is quite low.
That's it.
Yeah.
Okay, thank you. Any other question at the moment? Dr. Vân, do you want to have any comment for your student?
I think endophthalmitis is a very severe disease, and especially fungal endophthalmitis is more severe. I think it is the most severe disease. And as you know, we do vitrectomy only. We do vitrectomy on the solution, or I dilute with amphotericin B to wash all the vitreal cavity, and I discovered that the neurovascular, the reaction of inflammation and neurovascular progress very, very quickly during healing program. And for the exogenous endophthalmitis, fungal endophthalmitis, if it happened after traumatic, as Dr. Kuang said, the one of the vision, the prognosis is very poor, because the patient already used a lot of steroids, and it's one of the reasons. That's why the visual acuity, not even it's progressed very, very quickly and very severe. Even we use 3 medications.
Of course, fungal endophthalmitis is a very severe disease, and but I follow your treatment. It's also quite good treatment. But the most important thing is you just have 3 cases. The restoration is a very low case. It's a quite good result. But because in 12 case, maybe sometimes if the patient have a corneal ulcer and also perforation, and you have to